And today I want to share with you the latest on palliative care and what is taught in these conferences, seminars, and how can you use this information for your observership rotations so you can impress the attending that you're working with your knowledge on palliative care, which is something that we use constantly. Palliative care is one of those specialties that we consult constantly. So, if this is of your use, please like and subscribe. So, let's start. Every year, major universities, academic centers, they organize these continuous medical education conferences where you can pay, go, get your CME points, get the requirements to renew your medical license every year. And one of these requirements is palliative care continuous medical education. So not too long ago, I received this invitation from the Mayo Clinic to participate in these updates in palliative care 2022. And it comes in a little pamphlet to your house, and it kind of makes you aware this is going on. Usually, it's the best way because we're not always looking for these things unless we're close to the time where we have to start collecting our points. So, updates in palliative care. Let's see what is this about. Let's go to the overview. It's a course that offers live or virtual attendance options. It gives you 20 AMA Category 1 credits. Every year we need about 100 to 150 credits every 4 years to renew our license. And it's in a little hotel in California. The target audience includes MDs, NPs, PAs, whoever requires this type of points, then will benefit of this. Also, anyone else will benefit. Nurses, medical students, residents, anyone will benefit of such information. So it is worth it. The learning objectives, of course, to learn more about what is going on palliative care and what this program offers. Let's look at the program. So the importance of reading this is for you to not only to know more about palliative care, but since it is such an important topic in patient medicine, for you to get ideas what is in vogue, what is hot right now that I can do the same work in my institution, in my place, in my country, in my hospital. So, for example, this the program for this conference will start with on Thursday cases in refractory symptoms like nausea, dyspnea, constipation. What to do when usual meds don't work. That sounds so interesting. And if you think about that, you could make a poster presentation, a case report about refractory nausea, refractory dyspnea, refractory constipation. What is proven to work? For example, I know that for nausea, you can try Sofran, you can try metoclopramide, and you can even try lorazepam. You can even try Valium to stop severe nausea. And this is something that we commonly see. It's not that uncommon to see a patient that has chemotherapy that you cannot stop their nausea, or a patient with advanced diabetes that has gastroparesis that you cannot stop their nausea with simple methods, and you have to use, for example, erythromycin or any kinetics. Okay, so that's one. Then let's go to the next one. Acute and chronic side effects of chemotherapy: mucositis, xerostomia, dysgeusia. You can make a case report on this. The same idea. Why? Because it's relevant. It's relevant. We have a. If you're doing a rotation in a cancer center, you could do your investigation and do a case report or a poster presentation on the current management or recommendations on mucositis, xerostomia, dysgeusia. Very common topics at cancer centers. Next one, fatigue management in palliative care. What is that? Isn't that normal that patients with cancer feel fatigue? Well, it is, but there's also something that you can do. You can provide medications that will increase their energy, that they will force them to stay awake. So you need to know these medications. Next day, what they're going to do is using interpreters in palliative care. Always great topic. If you just want to start in your rotations you want to have 3 4 topics to present, and you're doing this at let's say at the cancer center, you could do this topic. You could say, what is said about using an interpreter in the palliative care? Why is this important? Why can't you use the family members? And you know that it's part of the questions that you use right now for your step exams. So it's true in things that involve very serious, very specific conversations. You cannot rely on an untrained medical professional. You cannot rely on an non-licensed medical professional to do your translation. For example, you cannot rely on the parents, you cannot rely on the daughters, sisters, if they are not doctors or they haven't had any training. So it is okay to rely on a nurse that is a native Spanish speaker, yes, because that nurse has gone through the training, but you cannot rely on someone else. And this has to be documented. When you have a conversation about the end of life, you have to document that you use interpreter that is a professional interpreter. Why? Because of course you know the barriers and limitations of people. Next one, this one is something I'm very interested is into. How do you deal with adolescents and kids? What do you recommend or suggest to these kids that are going through the loss of a loved one, and these children that are losing their parents, or the children that is facing a life-limiting condition? He's not yet an adult, but he's still a child. What can you do? What can you provide for support? What is there that he can help this family? Um, and of course, in one of these days, they will provide the testing for the ABFM points. This you don't need to know right now, and we're talking more about the topics. Next one, neuropathic pain. This is great because neuropathic pain is not only something that you will deal with at the end of life, you will deal with neuropathic pain um, every day in the hospital. And if you have a presentation, let's say you have to present a patient, and the case is of a patient that has severe pain, intractable pain, and it seems neuropathic. Instead of just saying, well, my treatment for this patient is going to be gabapentin, you could say the treatment plan or the strategy pain plan is going to be the use of gabapentin plus lidocaine patch plus continue to increase the dose of gabapentin until the pain seems to improve. Is different. So the way this is also good for you to learn the wording, the professional wording that you want to be able to use when you present cases. So very important to know what are the options for neuropathic pain treatment when gabapentin or duloxetine are not working anymore. Duloxetine is used at a high dose to treat neuropathic pain, and sometimes it doesn't work. What else can you add? This is a great topic. Methadone for refractory pain. When do you start using methadone? When is Percocet, Vicodin, morphine not enough that you have to go to use methadone? Important topic. In cancer centers, they use a lot of methadone. In regular community hospitals, you will find patients that will need methadone or have been on methadone already, and you have to know, you have to be aware that you are able to continue using methadone but not being able to discharge a patient and give him a prescription for methadone. So these are little things, but important for you to know about methadone for refractory pain for your rotations with an internal medicine team, with a palliative care team, with anyone, because palliative care is everywhere. Next one, coping, how to learn about coping mechanisms and how to transmit this to patients, very important. Next one, this one is something I want you to read on your own, and maybe it's a good idea to do a case report on this, on miracles, futility, and the family who wants everything done. And what is this about? Futility. Futility means that something may be done for a case that may not respond to it. That we are thinking this patient is not going to respond well to this treatment, and we don't want to do this. But we're doing it because the family wants to keep going, keep fighting. And how do you explain this futility? How do you explain to a family that the treatment that you're proposing is not going to work? if this family is fixed on miracles can happen, my father is a fighter, my father wants to keep going, how do you explain there is a line where we should stop um, basically torturing the body of this person and accept the the end has come to this person. But how do you explain this in a way that you're sensitive, in a way that you you convey that you are part of the team, that you want the best for them? Because sometimes families think that you just don't want to have to deal with this person, this patient. All right, next one. Depressed mood isn't depression, addressing demoralization and anticipatory grief. Good topic. You can you can learn about it. I'm not very excited about that one. Managing anxiety in patients with serious illness beyond benzodiazepines. And this is a good one because there are so many other things that you can use aside of benzodiazepines. Sometimes the family members say, "Oh, we don't want to use benzos. We don't want to hasten the process by using benzodiazepines," and that's fine. You can use different things. You can use melatonin. You can use um, Benadryl, you can use Haldol, Zyprexa, different things. So this is something that you could use to learn. And then are you underutilizing your social worker? Why? Because social workers have a lot of resources. Their training is to learn and know the resources that there is for the patients. So if you're not using your social worker well, it's something that you can in your rotation say, I'm going to communicate with the social worker and see what resources are available for this patient. And I will let you know, Dr. Munoz, I will bring you a list of places where this patient can go for shelter or can go to get food or can go to find a chaplain or a palliative care nurse. Next one, last day in the conference. Let's see which one looks something that I can tell you about. Um, Addiction and terminal illness. Most patients that are on terminal illness, they're really using the pain medications for real pain. So I wouldn't be able to tell you more about this. You can read about it. Um, this one is good. How palliative care has moved into the virtual world, into the telemedicine use of palliative care, because palliative care can reach um, patients even in a computer, in a laptop, and you can discuss things with patients, you can talk to them, you can follow up with them. And usually the way you do this is through hospice care. Nowadays, hospice care has the same limitations as anyone with the COVID pandemic. When we are doing hospice care, when we usually are supposed to go to see a patient in their house to monitor on their use of the hospice kit or the hospice medications that we have for them. That has been limited because of the COVID pandemic. Now, what we have to do is we have to do a teleconference and tell them how are you doing, how is your medication working, is the morphine 10 milligrams working for you, do we need to increase it, are you constipated, following up on all what we follow on hospice on a regular home visit now has been replaced with the telephone calls or to the teleconference where we still have the conference with the family and the patient, but is limited by that type of interaction. Um, the importance of frailty. The importance of frailty and how is this used as a prognosticate factor for serious illnesses. Very important because with this you learn that when you present a case for internal medicine, for cardiology, you can say this patient is frail. I don't think he will benefit of us going for an angiogram at his 96 years old just because he has an elevated troponin. I think the benefit, the risk of going through all that contrast, all those procedures is far higher than the benefit of this patient identifying a atherosclerotic lesion. And I would suggest this patient goes into hospice care for his advanced heart failure. And that sometimes is what the family wants to hear. and it's probably what your attendants want to hear, because that's what we hear all the time from them. If the patient has poor prognosis based on frailty, and how is frailty calculated, how is frailty scored through a performance scale. All right, moving forward, the use of marijuana and other psychedelics in palliative care, very very much in use these days. So you could learn how we're using marijuana, we're using the active components of marijuana to help patients with for like appetite stimulation, severe pain, nausea. So it is in use and it's getting more and more strength in the hospice and palliative care world. So, guys, this is it for today, and I think you should take a look on this. And this is provided by the Mayo Clinic. This is a whole list of doctors that are part of this presentation. You could also try to find some emails here that you can directly email and see if you can obtain an observership from them. For example, I will say the way I always do this when I suggest people to look for an observership is look at the names of the doctors. Okay, so let's see, Elise Carey. So she's a faculty doctor. So what will be her email? Let's look at somewhere in this pamphlet that has any email. Let's see, target audience, no one here. Accreditation, dun, dun. No one. Let's see, specialties. No, contact us. Let's look at the contact us thing. So the domain is at mayo.edu. So you could say for Elise Carey, it's gonna be Carey at mayo.edu. Or if the doctor is Jonathan Munoz, it's going to be jmunoz at mayo.edu. And if it bounces, then that's it. But at least you tried. Remember, this is a time that we want to try everything possible. So this is my presentation on this topic. Hopefully it was of use for you. And leave a message and subscribe if you can. Thank you.